Oliver Cornelli from the University of Cologne in Germany, where I work as the director and chair of the Translational Research and Clinical Trials Center. And what I do clinically is the infectious disease consulting work at the university hospital. We do have, together with the university and the university hospital, a European Mycology Excellence Center by the ECMM designation. And today's program is on the European Quality Scores for Infectious Diseases. For many diseases, if not most diseases, we do have guidelines. But what is inherent to each and every guideline is that we do not know whether they are being followed, and we do not know whether adherence to guideline improves patient outcome. And why don't we know these two things, these two decisive answers to these questions? The reason is that we don't have a tool to measure guideline adherence. And that is the idea behind ECMM, the European Confederation of Medical Mycology, initiating the process to develop or create European quality scores or equal scores. We've done so in many languages, 15 so far, and I'd like to lead you through the equal mucormycosis score. It's split into 3 parts, following the chronology of a patient, and that starts with diagnosis and then treatment and then follow-up. And I'd like to briefly go through it. So the equal mucormycosis score 2018, and actually all the details here have been published in a paper of Philipp Köhler in the Journal of Antimicrobial Chemotherapy this year. So it starts, as said, with a diagnosis. There is neutropenia for more than 10 days, or allogeneic stem cell transplant recipient. They should receive mold-active prophylaxis, and ideally that prophylaxis would cover mucormycosis too. And there is an A1 recommendation for that, and that's why it earns you 3 points, because that is what you get if you follow an A1 recommendation. In case of persistent fever, a chest CT should be done, and then the next diagnostic steps, no surprise, address what do you look for on the chest CT scan, and depending on the finding, what are the next steps you should undertake. If there is a so-called inversed halo or reversed halo or atoll sign, it's all the same. If you find that, then you go for a CT or MRI staging of the patient, because it might be disseminated disease and you don't want to focus on the lung alone and then forget about something and overlook something that's happening in the head or in the abdomen. So any inversed halo, like any infiltrate, should receive or trigger a bronchoalveolar lavage, a BAL, and then there are different tests given on the slide that should be done on the BAL fluid. And if microbiological test results are negative, then you should go for a biopsy. I know it's not easy, and being a hematologist, I perfectly know that you sometimes really have to wait until the platelet counts recover before you can even think of a biopsy. But those who should do the biopsy, so interventional radiologists or surgeons or whoever, should be involved early enough, even at a time point where such biopsy cannot be done yet, so that they know about the patient. Because once the platelets come back, that might be a very rapid recovery, and you don't want to lose time if that happens on a Thursday and then a biopsy is only done on Monday. You want to be fast, because diagnosing properly and really determining the cause of the disease in your patient will likely be life-saving. If an isolate from any of these measures grows in culture, then it should be identified to species level and should be tested for its susceptibility, but that is a somewhat weaker recommendation. As you can see, it gives you only 2 score points and not 3. Brings us, after the large diagnostic part, to treatment, and that's first-line treatment. Surgical debridement, and that could be the same step together with the biopsy. Should be done, and ideally you would achieve microscopically clear resection margins. There is limited info on that because it's burdensome to do, but apparently it's not impossible, so we might all want to strive for that. Liposomal amphotericin B, if that is the drug that you would choose, you would, according to the guideline, give 5 or more milligrams per kilogram per day, or the alternatives are isofuconazole. In many countries that would be off-label, in others it's within the label. The same is true for posaconazole. I guess that would strictly be off-label for that first-line treatment situation, although there are data for all these 3 antifungals in that situation. TDM is recommended by the ECMM and other groups and entities that publish guidelines on the disease. And that's certainly reasonable, and it would give you 2 points if you do TDM. And then you should control the risk factors, or we should control the risk factors of our patients to the extent possible. That's not easy with neutropenia. It's certainly much easier with hyperglycemia or ketoacidosis or corticosteroid treatment, which should be stopped or at least reduced to the absolute minimum necessary to be given to the patient. The third part of the card, of the score, is the follow-up, and that's pretty easy because you would go for a CT scan on day 7 and on day 14, and then likely continue weekly CT scans until improvement, and then you can widen the windows between the CT scans, the intervals. So what is the maximum score you can earn? Well, this depends on whether there is an isolate that you were able to prove in the case of your patient, or whether it's histology only, whether biopsy could be done at all, and whether you have both, a biopsy plus a growth in a culture. That is ideal, of course, but not very often accomplished. But that makes it clear why there are 4 different categories, and that is why the table is somewhat more busy in that part, where you can have a total score of 25 all the way to 32 score points. This card can be downloaded through the QR code given on the slide, and you can easily identify it because we have that nice little sketch of a mucor pathogen up here. And it leads you through diagnosis, first-line treatment, follow-up, as done in this talk, in this presentation, and explains in brief words how the score was composed and what is the result and what the actual publications behind are. So, how can we use the equal scores, the European Quality of Management in Infectious Diseases scores? We can weigh and aggregate recommendations with these scores, and they display what would be an ideal disease management. So the scorecards hopefully are a useful tool for measuring guideline adherence, for antifungal stewardship, and to facilitate clinical decision making, because if this is a pocket card, then you can always easily have a look and see what additional diagnostic or treatment steps should be taken next. The equal scores provide an easy to follow algorithm, and they are in different languages. And for the moment, that is Albanian, English, French, German, Greek, Hungarian, Italian, Kurdish, Polish, Portuguese, Romanian, Russian, Serbo-Croatian, Spanish, and Turkish. But there are more translations to follow. If there are any languages that you would want us to translate this to, let us know. Thanks a lot. Have a good day.